Okay, good afternoon, everyone, and welcome to Primetime Alive. I'm Danielle Linder, and I work closely with Vicki Newell to support the Primetime Alive program. So I'm here for Reagan for today. So thanks for joining us. As a reminder, if you'd like more information about Primetime Alive or how to join, please visit our website at mgmc.org/PTA. Today, we're welcoming Susan Moore and Nick Torres to talk about mental health. Unfortunately, his Nick's partner, Becky, was unable to join us, so we're short one presenter. Susan graduated from the University of Northern Iowa with a degree in social work. He's worked in mental health for 31 years. The past 10 have been at Mary Creek. Currently, she's a behavioral health and community outreach social worker. Nick completed paramedic school in St. Louis in 2012 and has been at Mary Creek since 2016. He's currently a paramedic with the ARCH program. Please welcome our first presenter, Susan.
Hello, I'm so excited that everybody is here to talk about mental health with us today. So when I give this presentation, I really like this to be informal. If I'm talking about something, you have a question, I think we will have plenty of time to just raise hands at the time and ask that question. So yeah, we will go ahead and get started. So again, I've been at Mary Greeley for 10 years. And part of my job does, oh, thank you.
I forgot we have a microphone. Sorry.
Okay, is this on? Okay, perfect. So I'm usually a fairly loud speaker anyway, but it's probably better that I have this with me as well. And I will get up and move around. So we are going to be talking about mental health today. Can you do the slides, please? So what is, and I apologize. I tried really hard to get the font to be a little bit bigger. That's some feedback I got sometimes. So we'll go ahead and go over the slide as well. And it looks like maybe you have the slides in front of you printed, which is good as well. So what is mental health and how does it affect us? Mental health includes our emotional, psychological, and social well-being. It affects how we think, feel, and how we act. It also helps to determine how we handle stress, how we relate to other people, and how we make healthy choices. Mental health is important at every stage of life, from childhood and adolescence through adulthood. So good mental health is when you feel like you can manage those day-to-day stressors that we have, be productive at work, and use your abilities to contribute to society. Good mental health is a part of being happy with your life, being connected with other people, and having a sense of meaning in your life. Resilience allows you to cope with challenges by using inner strength and your support networks. Investing time and energy in your relationship with family and friends is important for mental health. You can build good mental health by maintaining a healthy lifestyle, practicing gratitude, and contributing to the community along with doing other things that you enjoy. That didn't help. So some signs when our mental health could be declining, when we're feeling sad or down. I will add that it is normal for all of us to have those days when we feel sad and we feel down. Especially during this time of year, when we talk a little bit more about depression, we'll talk about, there's some mention of like seasonal depressive disorder, and we'll touch on that, but it is normal to feel down. And sometimes we have maybe more than one day when we're feeling really down. So who's seen the commercials on TV for like the medications, like Cymbalta? Okay, yes, and she wears the mask. I actually kind of like that. But they always say at the end, how long do they suggest that you wait before, or that you go before you see a doctor? 2 weeks. So if your symptoms last longer than 2 weeks, they suggest that you start by seeing typically maybe your family physician. Your general practitioner can be a really excellent place for you to start. If you're having symptoms that are lasting longer than 2 weeks, I tell people you just have to wait that 2 weeks. If you're really feeling miserable, please make a doctor's appointment and go sooner. That's really important. I don't ever want to send the message where people think, oh, it hasn't been the 2 weeks they suggested, so I'm going to have to wait. Don't wait. We know ourselves. If you need to go see someone sooner, by all means, go see someone sooner. Confused thinking, we're not able to concentrate as well. Excessive amounts of worry or extreme feelings of guilt. Extreme mood changes, really high highs, really low lows. Withdrawal from friends and activities. And we'll talk a little bit more about that when we talk, how can we help each other? That can be an indicator maybe that someone is struggling. Can be that, hey, you know what? I haven't seen this person at coffee for the last week. That seems really weird to me. Maybe I need to check in with that individual and just see that they're doing okay. And it may be that their schedule just didn't allow, but a check-in is always a good thing. Kind of looking for changes in routine. Sometimes we also have people, and I don't want to get too much into this because we will when we talk about depression, changes in hygiene, just changes you might notice about each other. Significant tiredness, low energy, or problems sleeping. And again, when we talk about depression, I'll get more into that because for some people, it looks like the exact opposite, where they are not sleeping. And that can be what depression looks like for people, is that they're not able to sleep. Detachment from reality, having some delusion, some paranoia, or some hallucinations. Inability to cope with daily problems or stress. Trouble understanding and relating to situations and people. Problems with alcohol and drug use. Major changes in eating habits. And again, for some people, this looks like not eating. And for some people, this looks like eating much more than they typically would. Changes in sex drive. Excessive anger, hostility, or violence. And some suicidal thinking. So it was a lot of information. Any questions so far? A lot to think about. Okay, so we have depression. So I chose mental health diagnoses that are probably the most common. Raise your hand if you feel comfortable, you know some things about depression. Okay, good. So we've got almost everybody's hands are up. Okay. So depression is a mood disorder, and it's a persistent feeling of being sad and having a loss of interest. When I work with people, it's very common when I ask them what some of their strengths are, or when I ask them, tell me what you like to do. What are some hobbies? And it may be I used to like to do this and I haven't felt doing that for a really long time. Right now, I just don't do much of anything. Depressive disorder, also called major depressive disorder, clinical depression affects everything about us, how we feel, how we behave, and can lead to a variety of emotional and physical symptoms. What do we think some of the physical symptoms could be of depression?
Of appetite.
Loss of appetite. Thank you. What else? Headaches. Yes. Tiredness. You're right. So
Isolation.
Isolation. Yes. Thank you. So thinking about all of those things, and sometimes people will report that they just feel achy. Like my muscles hurt, my joints hurt. I just feel really achy. And sometimes that is what winds people up at the doctor's office to start with. And sometimes it's obviously something else. And sometimes it can be, hey, let's talk a little bit about your mental health. And how, have you been feeling, and your doctor asking you those questions. So sometimes it can start off really vague, not the obvious ones, like we said, with the sleeping and the eating, all of those things are signs, but sometimes it just starts off with hey, I just feel kind of icky. I just have some kind of unexplained aches and pains. Depression, you may have trouble doing normal day-to-day activities. And sometimes that comes with feeling like life is not worth living. Depression is more than just a bout of the blues. Depression isn't something that is a weakness that people can just snap out of. Depression can require long-term treatment. Sometimes that looks for people like medication. Sometimes that looks like therapy, or sometimes it looks like both. But again, I just want to reiterate that depression is not something that individuals can just snap out of. I show this awesome TED Talks, and it's a gentleman who is 19 years old. He's a stand-up comedian. He shares the story about depression. And one of the things he said is depression isn't about when we have a lot of things in our life that are sad. Depression is about when we have a lot of good things in our life. We should feel happy and we don't. And I'm like, that is so cool and so true. Depression isn't just, and can be when we have sad circumstances, but can also be when everything is going right. And then sometimes that can come with a lot of guilt of, why am I feeling this way? I have a great house. I have a great family. I have great kids. I have so many things going on in my life, but I just can't be happy about these things. So although depression may only occur once during your lifetime, that's typically people are going to have multiple episodes of depression. And then these include, and we kind of talked about this already, feelings of sadness, tearfulness, emptiness, or loneliness, angry outbursts. I have known people that depression looks like extreme anger and extreme irritation. I mean, they just can't tolerate anything. They can't tolerate someone talking too loud. They can't tolerate someone shutting a door too loud. And that's what depression looks like for them. Lots of interest in all those activities that you used to like to do. Sleep disturbances, which I already alluded to. I didn't want to jump ahead and I did. Including insomnia or sleeping too much, feeling tired and not having any energy. So really, even those small things feel like a lot of work. Running errands can just exhaust you. Reduce appetite and weight loss or weight gain. And then anxiety, agitation, or restlessness can all be some, and this is not an exhaustive list. These are just some things that are pretty common that you might notice either in yourself or maybe someone else. So we talked a little bit, or I alluded to, there are some different types of depression. And so please see your doctor. Your doctor can provide more clarification on this. But I just thought that this was noteworthy. We have anxious distress, depression with restlessness, worrying about events or loss of control. And by events, that could be something that probably is not going to happen, but being really, really excessively worried about that. Mixed features, which is depression and mania, which includes elevated self-esteem, talking too much, and increased energy. Before I move past this one, I want to make sure that everybody understands mania. Do you want me to go over that? Okay, yeah, absolutely. So when someone is manic, you are going to see that they have energy like you've never seen before. Sometimes when people are experiencing mania, they will be up for days. They are getting things done like they've never gotten done before. I have seen people make some pretty impulsive purchases when they were manic, that when they were no longer experiencing mania were very remorseful. People when they're manic can engage in some reckless behavior activities that they wouldn't do. And there are people that enjoy being manic because they will tell you, I've never had this much energy before. I've never been able to get this much done. So do you guys feel comfortable with that explanation? A little clearer picture? Can I provide some more examples?
No, but it sounds pretty good. I might get my house cleaned.
Well, and so that's what
Before last.
that's what people say. We will have people that say, I love feeling that way because I get things done in my house. I got my house cleaned for the first time. I did all these things. Yes.
I understand what you said about is,
Mhm.
but is it a chemical imbalance that causes it?
Yes. A lot of the times we find when someone comes to us and they are experiencing mania, they either, number one, haven't been taking their medication, or number two, have not been diagnosed and taken medication. Yes. And mania can last for long periods of time. But yes, I've seen people that have been up for days that are manic. Melancholic features. So that's going to be our severe depression again. And you kind of see a theme with this. A lot of our themes with depression are that we've lost interest. Sorry, I had a moment there. Lost interest in something that we used to do. And we may have getting up much earlier in the morning, worsened moods in the morning, major changes in appetite, sluggishness. Again, you kind of see similar features in all of these. And then the atypical features is depression when we're not happy. And I alluded to this, we're not happy with things that used to make us happy. Events when we think, I should really be happy that my son just bought a new house, yet I can't. I should be really happy that something happened, X, Y, or Z. And I can't. I can't get happy about that. And this is going to be your increased appetite. You're going to find someone sleeping more, sensitivity to rejection. I call this sort of big feelings. You may see a response that's much more exaggerated. And you'll think, wow, that seems really strange. I wonder why they had that strong of a response to something that I just said to them. And then this last one actually has some physical things, and that's feeling heavy in the arms and legs. And I talked about that a little bit earlier, about some physical things that can go along with depression. And so this one is, again, the feeling heavy in the arms and feeling heavy in your legs. Okay. So we have different types of depression. We have psychotic features. So this is a type of depression that's going to be accompanied by delusions or hallucinations. Do we need to talk a little bit in more detail about delusions and hallucinations? Do we know what those are? Okay, I'm seeing most heads say yes. Okay, just wanted to double check and make sure. I didn't want to gloss over anything. And also may involve personal inadequacy, just other negative things. Catatonia is a depression in which motor activity that involves either uncontrollable and purposeless movement or fixed and inflexible posture. Catatonic and depression may look like someone who sits very stiffly and doesn't say a word. That can present as that. Prepartum onset, that's during depression, during pregnancy, in the weeks or months after delivery. And then our seasonal pattern, which is what I had mentioned earlier, depression related to seasons, the changes in seasons. We haven't been getting a lot of sunlight lately. We just have not been. There were days when I went through and I said, when I got home from work, I said, geez, I left this morning, it was dark out and I'm coming home and it is dark again. And that just does not do a lot for our moods. We need to have some sunlight. We need to have that. That's really important. I used to tell people too, I recognize in myself, my cranky time is usually right after Halloween until about April. So that's a long time for my family to bear with me. But this season, I just don't love this time of year for a lot of different reasons. And I've come throughout the years to kind of recognize what that is and to be mindful and to plan for that and knowing, hey, what can I do? I know this is my crabby time as I refer to it. So what am I going to do to keep myself healthy? So that's really important too. Okay, so we've got some facts about mental health and aging. So first thing, mental health problems are not a normal part of aging. When we get older in life, we may experience more losses, sadness that lingers and may result in clinical depression, and possibly an anxiety disorder from worries. And we'll talk about anxiety. I think we're going to be coming up on that slide here shortly. Good mental health is just as important as physical health. And I really can't stress that enough. Taking care of our brains, the brain is the part of our body. Taking care of our brains is just as important as taking care of everything else in our body. And when you think about mental health, there has been a campaign to start calling it brain health. So you may hear it referred to as brain health. Same thing. Good mental health really contributes to how we feel overall. Unrelated mental health disorders in adults can diminish our functioning. Substance use, poor quality of life, and increased mortality. Research shows mental health can slow healing from physical illness. Older, healthy adults can continue to thrive, grow, and enjoy life, reading, walking, socializing, doing whatever works for you. Be active. I talk with our patients a lot about just do something. That's kind of become our motto. And some days just do something feels really overwhelming. So get out of bed and say, I'm going to walk around my kitchen 5 times today. And if I get that done, I'm going to be really happy. But just do something. That's become our motto. Just do something. Now I lost track. Oh, there we go. Exercise. Thank you, Nick. Exercise your mind and body. Maintaining social connections are good for your mental health as well, too. Mental health problems are a risk for older adults regardless of your history. So sometimes adults go through managing chronic mental illness. We think about mental health problems that happen later in life, as well as physical things that happen later in life too. Sometimes mental health can deteriorate in response to a stroke, Parkinson's. I don't see another one up here. Dementia. Cancer, arthritis, diabetes, even some medications. I mean, the list just is extensive. Older adults without a history of substance use may also abuse medication, alcohol, or drugs too. Suicide is a risk among our older adults. Older adults have the highest suicide rate in the country. And that is really shocking to some people. We think typically about like our adolescent age as being higher in the percentages. It's actually our older adults. Those age 85 and over have the highest suicide rates. Those age 75 to 84 have the second highest rate. Older suicide attempts are more lethal. For those 65 and older, there is 1 suicide for every 4 attempts compared to 1 suicide for every 20 attempts for all age groups. So I apologize. I probably should have backed up and given a trigger warning, and I apologize that I didn't do that. Talking about suicide can be really traumatic for people if you've lost someone to suicide or you know someone. So I do apologize for that. If you need to get up and take a break, please do. Please do that, because this can be really difficult to hear, especially when you've experienced that loss. So I apologize. I used to have a slide that said trigger warning on it, and I got rid of it. I probably should have kept it. So symptoms call for consultation with a healthcare professional. Last longer than 2 weeks. There's our 2 weeks. Again, I'm going to tell you, don't wait 2 weeks because you think you need to. If you are experiencing something and it's been a really tough week and you're like, hey, I need to go to the doctor, make an appointment with your general practitioner. Great place to start. Consistent worries about money, family, and health, trouble sleeping and concentrating, frequent trouble remembering things or feeling confused in familiar places, have 1 or more alcoholic drink a day, or take more medication than is prescribed to you. Older adults can be helped with the same success rate as anyone. 80% of older adults recovering from depression after receiving treatment that included both psychotherapy. So they're referencing like a counselor or a therapist. I use those words interchangeably. They both can help you with the same purpose. Really, the difference is how we're credentialed. It doesn't really matter. Just know that they both can help you. And maybe an antidepressant medication. Our healthcare system is not adequately helping older adults with mental health disorders. And we find this to be true. Medicare covers 80% of the cost of physical illness, but only 50% of the cost of treating a mental health problem. That is so true. That is so true. When we schedule, and I say we as in myself and our nurse case managers, when we schedule appointments for people, it's easier to find people that will accept Medicare if we're talking about our mental health. If we're talking about someone that needs to have some substance use treatment or counseling, that is a challenge. That is a challenge when you have Medicare. 75 people who complete suicide have visited a primary care physician within a month of their suicide. This says commit suicide. We don't really like to use that verbiage anymore just because it makes it sound like someone like committed a crime. And so usually we would say like died by suicide, a suicide completion. I've also heard people maybe say like died from mental illness. Might be a reference to. So misdiagnosis isn't avoidance or common. Primary health care physicians don't necessarily always diagnose depression. But I find on a positive note that if they don't know, they will tell you, they will help you to find a psychiatric professional. I feel like general practitioners are really good about that. If they feel like there might be something there and they can't adequately help you, they will refer you to someone. Half of the older adults who discuss mental health problems meet with the physician, receive treatment. Older adults have specific mental health care needs. Our bodies change, our chemistries change, our families change, our friendships change, our living situations change. I mean, you see all of these things. There's just so many changes that happen. Let's see. Oh, if older adults take medications for illness, drug interactions and side effects can change moods and behavior. So you can just see there's so many things that are specific when we're aging. Okay, so now we have anxiety. Is everybody familiar with anxiety? Okay, yes, okay. I see lots of smiling and laughing. Yes, we all know about anxiety. I get anxious every time I get in the elevator at the hospital because I think I'm going to get stuck. You would think after 10 years that would pass. Not really. So I just have to be okay with being okay on the elevator. The most common category that we see in America is anxiety. 40 million adults 18 or older have been diagnosed with an anxiety disorder. So that's a fair amount. That's a fair amount of people. Anxiety can cause people to experience distressing things, fear, apprehension. I don't like the word normal, but I'm going to use it. I'm going to say anticipated. It's anticipated that before we do something like a job interview or meeting someone new, we're going to feel some anxiety. That's anticipated. These are disorders when things go way past that's anticipated mental health. Anticipated anxiety. So we've got, this is really small. I do apologize for that. So we've got GAD, which is generalized anxiety disorder. Yes. Oh, good. If you guys want to look, thank you so much for pointing that out. This one's bigger, folks. If you want to turn your attention up here, generalized anxiety disorder is the most common. You will see they refer to it as GAD. It is characterized by excessive worry, issues and situations that individuals experience every day, but the worry really in a nutshell is out of proportion for what you're experiencing. Next one is obsessive compulsive disorder. Okay, so this is the need to repeat things over and over again. I share this when I do this presentation. I think it's a Julia Roberts movie, but do you guys remember when she opens the cabinet and all of her food items are like stacked evenly and the labels are, okay, you remember,
Yes.
facing the same direction. I can't either, but she's in that movie, and that can be an example for some people of what OCD looks like. Not everyone. Some people have counting numbers that they do in their head. Some people can't leave the home without checking the door 10 times. So unfortunately, it looks like for them, like it's going to take me an extra hour to get out of my home if I even get out of my home. We had the example that I gave you about everything in perfect order. I mean, there's lots of different symptoms that go along with having a diagnosis of OCD. Panic. Someone who experiences frequent sudden panic attacks. Having a panic attack does not mean that you have a panic disorder, but instead a pattern of panic attacks. Maybe something to look at is possibly having a panic disorder. So we have post-traumatic stress disorder. This is a triggering traumatic event. Those who experience violent combat, witness a terrifying event, may develop PTSD. The thing about trauma and PTSD is it's all unique to each one of us. What can cause me trauma may not cause Nick any trauma, and we've been at the exact same thing and experienced it. So trauma is really very personal. When we think about like a community event or something big that's happened, it's possible that several people may develop PTSD, and then there may be people that don't. And social anxiety. These are the people that said I did best during COVID because I didn't have to go anywhere. I got to see my doctor on the cute little computer screen. Someone brought my groceries to my house, and I loved that because going out socially causes me so much anxiety. Like I can't do it. Like I can't be in a room full of people. For some people that looks like, and this was back when Walmart was open all night. I'm up getting my groceries at 2 a.m. because there's nobody else there. People, or it may start out as I'm going to have my groceries. I'm going to do pickup. That's too much. I'm going to do delivery. And then we have people who aren't leaving their homes anymore because of social anxiety. It can be really debilitating for people. Oh, okay. So here's our short video. It's about 2 minutes.
One thing that people don't recognize is that worldwide, men and women, as they get older, are at greater and greater risk for suicide. I think it's important and helpful to know that there are just a few things that we associate with suicide in older adulthood that really can be fixed. And when we change those things, when we recognize them and then intervene, that trajectory towards suicide actually can be altered and lives can be saved. The things that pop out and that place older adults at risk are first, depression. And by that I mean clinical depression. Older person with clinical depression typically is going to be sad. They're going to have lost interest in things that commonly interest them. They might be anxious. They might have trouble sleeping. They might have lost their appetite. Feel a lot of somatic symptoms, as we call them, things like pain and stomach upset and that kind of thing. Another is what I call the second D, is debility. It's the idea that even though older people ordinarily almost have one or more chronic illnesses, when that illness or illnesses mount up, when they begin to have an impact on the person's functioning, their ability to maintain independence, and in particular has impacts on things that are personally meaningful. The third D, as I think about it, is disconnectedness. We know that's very important for older people to maintain social contacts and social connections. And so if an older person is withdrawing from or is required to withdraw from social interactions because of physical illness and functional impairment, that disability, or because they're depressed and it's hard to interact with other people, that's an additional risk. The fourth D I think of as access to deadly means. A lot of people don't recognize that that fully among older men, which again, as I said, are by far the highest risk group in the country, over 3/4 of older men who take their own lives do so with a firearm. And of older people over the age of 65 who die of a firearm injury each year, 92% are suicides. So having a firearm in the home, we know, of an older person who has these other Ds going on in their life is at significantly increased risk. Older adulthood is not a time when it's normal to feel depressed. It's not a time when it's normal to feel as if your life has no meaning. And if those things are coming across, that should send up a red flag and indicate a time for some additional evaluation, because these are things that can be changed.
Okay, so this is going to be another look to your right or left. This one looks bigger than the other one. So how can I help? So what can I do if I notice or I have some concerns about a friend, a relative, a colleague, someone who may be experiencing a mental health crisis? So what can I do? So it really can be really challenging to start those conversations. When we know that there's an issue, it's important that we don't wait. Waiting and hoping that they'll come for help can really lose some valuable time in getting them connected with the services that they need. So there's some tips here that I think are good. Talking to someone can be that first step. And it may be as simple as, hey, I'm worried about you. This is what I see. I haven't seen you at coffee for the last week. I noticed that you've been having difficulties concentrating. It can just be letting someone know, I see you, and this is what I see, and I'm concerned about you. When we talk about it, setting a time with no distractions, that's really important. I know we all get distracted by phones and a million other things, but setting those times when we're not going to have those distractions and letting people share as little or as much as they want to. It's very possible that that person may say, nope, I'm fine. We may both know that they're not fine. But when you plant that seed with someone that, hey, I am here for you, they may come back and say, hey, you know what? Nick stopped me last month and Nick was concerned about me. You know what? I think I am going to take some time to sit down and talk to Nick about what's going on. Let that person really take the discussion at their own pace. They will tell you things as they're ready to tell you. Talking and being vulnerable can take a lot of trust and can take some time. You may be the first person that they've ever shared some of this information with. Don't try to diagnose or second guess their feelings. Well, you may be happy to talk and offer support, not a trained counselor, and that's okay. Just remember to try not to make assumptions about what's wrong or jump in too quickly with our own diagnosis or solutions. And I think that's a big one. None of us like to see someone that we care about suffering. And a lot of times we are fixers. So we want to come in and we want to help someone fix something. And a lot of times that initial conversation is creating a safe space for someone. That is not saying anything. That is just allowing that person to tell you their story. Sometimes I will ask people, okay, do you want me to provide you with some suggestions or are you just wanting me to listen? And they may tell you, just listen. So let them, again, lead the tone of the conversation. Keep questions open-ended. Why don't you tell me how you're feeling? Ask lots of open-ended questions. Try to keep your language neutral. Give that person time. Sometimes when I meet with people, we will sit in silence for a little bit and I give them that opportunity to formulate how are they thinking. or I'm sorry, how are they feeling? And it may give them a little bit of time to put that into words. So allow that. Having silence is okay. I know it makes us feel uncomfortable and awkward sometimes. And it's something personally I've been working on. It's okay, Susan, to let someone sit in silence. There's a lot of benefit to that. Talking about self-care and how we take care of ourselves. Anything that we can do. Self-care doesn't have to look fancy. Maybe it's I'm going to have some quiet time and read that book I've been wanting to start for an hour. Sometimes for me, self-care looks like I am going to stop at Starbucks today and grab that coffee. I'm going to take that extra 5 minutes and get that coffee. Exercising, getting a good night's sleep, all important things. Listen carefully to what they're telling you and repeat back to them. Sometimes that looks like, okay, so I hear you saying that you are feeling upset because you had something happen with a coworker. Parroting that back so that you understand, so you don't have this long conversation with someone only to recognize that you two are not talking about the same thing. And making sure that we're getting that back and making sure that we understand and that people really know that we're listening as well when we do that. Offering them help in seeking professional support. Can I go to the doctor with you? Can I find a friend or family member? If I'm not the person that you want to talk to, who do you want to talk to? We're not always that person, and that's okay. Can I help you find that person that you want to talk to? Who can we call? Who can we invite in? And knowing your limits, you will have your limits on the support that you can provide, and that's okay. Take good care of yourself as the person that provides that too. Self-care is not only important for the person that's experiencing a mental health crisis, but for that person that's providing care. You need to take care of yourself. That's a conversation that I have with a lot of families. How are you taking care of yourself? What are you doing to make sure that you are okay during all of this? And that's so important. And again, try not to take things personally. Even if it's a close friend and they don't want to talk to you, that's okay. If it's, again, I can't reiterate it enough, it's not me, who can I get you connected with? I'd really love for you to talk to someone. Okay, so crisis. So this is a little bit different. In this one, someone is having a crisis. Someone has expressed that they're feeling suicidal. One of the first things in a crisis is to stay calm yourself, even though you might be panicking on the inside, like, oh, I'm not prepared for this. Staying calm is really important. And it helps literally to bring the temperature down in the room and gives confidence to that person. There are some strategies you can use to help. We listen without making judgments and concentrate on their needs at that moment. What do you need to do to feel safe for now? We use that a lot. What can we do to keep you safe for now? What is that going to look like for you? Do you need a ride to the emergency room? Do you need to go and stay with your parents or a friend? Can I get you there? What do I need to do to keep you safe for now? Ask them what would help. It's one of my go-tos is, what do you need? How can I support you? What do you need? Assure that there are resources out there that can help them. Avoid confrontation. Ask if there's someone they would like you to contact, and encourage professional help. Sometimes, and this will be kind of a lead into Nick talking, so this is a good thing. I just have a couple more things I'm going to hand off to Nick, because that looks like, what does professional help look like sometimes? And how can I get that? If they have already done something to hurt themselves, you need to get first aid immediately. If you come upon a situation where someone's already hurt themselves, we need to get help immediately. Seeing, hearing, or believing things that no one else can see can be a symptom of a mental health problem. We have individuals that have diagnosis, if it's maybe a schizophrenia diagnosis, that causes individuals to see things and to hear things that the rest of us don't. But please remember, they are very real and very frightening to most people. That is their reality at that time, and they are absolutely terrified. Because it's their reality. So kindly remind the person who you are. Sometimes I will tell the person, no, I don't see the person in the car that you think is following you. I know that you see them, and it sounds like that's really scary for you. but I don't see that person, but I know that you do. And acknowledging how they feel. Okay, so we've got 988. Is everybody familiar with 988, the crisis line? Okay, so you dial 988, and that is going to get you set up with someone. It's a crisis line that we use. You literally just pick up the phone and call 988. And they will have crisis counselors available to talk with you.
For any county? Is that for all counties?
Yes, that is nationwide. So that's a universal number that you can use. That is a great question. Oh, you can text too. If somebody wants to text them. Next time is our mobile crisis. This starts with Your Life Iowa. When you call them, they will ask you what county you are living in. You tell them I'm living in Story County or Boone County, wherever we're at. Because if they need to send out emergency crisis team, they would know who to activate. So when we call Your Life Iowa, again, if you're agreeable, if the person you're with, yourself or your friend or family member is agreeable, they will send out 2 trained professionals to help further with the situation. And so again, each county or mental health region has different responders and how they respond. We have what's called Irely Ball. If you're familiar, they're the community mental health provider. Irely Ball is our crisis team in Story County. Okay, so Nick is going to talk about another program.
Yeah, I'm gonna stand. I need to stretch too, so.
Sorry, I
I'll move
didn't
my
stand.
water. No, it's okay. So I might lean or stand, but so my name is Nick. I work as a paramedic at Mary Greeley. I've been there 10 years, just about somewhere in there. So we started a program called ARCH. It's Alternative Response for Community Health. And I'm going to kind of explain what it is and a little bit of what we are trying to accomplish. So do you want to, I'll put the stats up on the screen from last year. So we've been around since we launched in October of 2022. I guess you can't really see them. I should have made the slide a little less faded on that side. I just see them now. But I'm going to tell a story first while you can kind of look at those stats, and I'll explain those in a minute. But how many of you have kids? How many of your kids have ever wrecked something in your house? Damaged a wall? Right. Okay. It's good. Me too. So that's where the story comes from. So like was mentioned earlier, I lived in St. Louis for a while. And when my kids were little, we lived in a house that was about 100 and some years old, an old city house, right? And in this house, there was 3 floors and a basement, but the 3rd floor was like a finished attic. So we had this attic upstairs and then an upstairs, the main floor, and then the basement. And the person who lived there before had finished the attic. So there was like a half bath in there that was kind of weird because it had like a slanted roof toward the end. So it was a really weird little half bath, and it was finished and carpeted. And my kids slept up there, and it was like a playroom for them. So it was just this big open room, as you can imagine. So one Saturday I'm I'm taking care of my own kids. I hate it when people say, oh, you're a dad, you're babysitting. No, I'm not babysitting, they're my kids. But my wife was at work. I worked full time, she worked part time. So it was Saturday, she was at work. I've got 3 kids at home. The youngest is must have been just a few months because it was Super Bowl weekend. I remember that this happened. She was born in October. So I had a little one and then 2 other kids, right? So the little one's down for a nap. The other 2 didn't really nap. They just played up in the attic. And so I'm downstairs and I'm doing something on the computer. I don't remember what, probably wasting time really, because I finally had a minute to myself. And it was a Saturday afternoon. And they came down. I would usually go and get them, but they came down to me and they're like, Papa. And I'm like, what? There's water coming out of the floor. And I was like, so they had been playing up there, so I go up 2 flights of stairs to the attic, and sure enough, there's water coming out of the water supply pipe for the toilet, and they had snapped the PVC off, and they had snapped the shut-off valve with it. So it's just a half inch of PVC of free-flowing water into the attic. So it starts flowing over. So I panic a little bit. I'm like, okay, go downstairs. And I got towels first because I'm like, well, I can pack this wound, right? Like that's what I'm trained to do. I'm trained to, throw the towels down and we'll worry about the rest later. So I ran downstairs after I put the towels on the floor, ran downstairs, and first thing I'm going to do is shut off the water in the house. Because I'm like, okay, let's start there. Being an old house, all the pipes go every which way, and there's not really a clear indication of which one does what because they're all over the place. And the guy before me had renovated the house himself, so there was a lot of probably things that you wouldn't have a contractor do, right? So I go down to the basement and shut off. I knew where the main water was because I knew how to shut off the gas, the electric, and the water. Those are the three things as a homeowner you should know, I think. So I shut off the water. I'm like, okay, crisis averted, right? So I still run upstairs. I'm like, I got to clean up this water mess now. And I'm trying not to be mad at the children. That's hard as I'm trying. So I run upstairs, 2 flights of stairs, and I take the towels off because they're soaking wet by now. And I've got a few more towels with me. And I move the towels over. So like most of it's carpet and the bathroom's tile. So I'm trying not to get water on the carpet. And I take the towels away and it's still flowing water. Like, that's weird. Well, maybe it's just the last little bit. So I wait there a minute and I'm kind of sopping it up, and no, the water's still just gushing out of here, like regular flow of water. So I'm a little worried. So, and I'm a little upset too. And I ran downstairs, 2 more flights of stairs down to the basement, and I'm out of breath. I'm like, okay, so now what I do is I followed the water line from where it comes in the basement and shut that one off, shut that one off. I'm following them all along the pipe, right? But they split off every which way. So I'm shutting them off. I shut as many as I can find, shut them all off. I don't care. I'll figure it out later. So I get as many as I can shut off and I run back upstairs. I'm like getting a workout into. Yeah. And do the same thing. I move the previously dry towels, now wet, take them away. Still water coming out. So now at this point, so imagine, so I've got 4 different layers of house, and there's water cascading down all 4 layers, all the way to the basement. So there's literally a waterfall in my house. I had these French doors from the front porch area, front, boot room, whatever, to the living room. There's French doors, and the water's just like flowing down between. I'm like, I don't know what to do. I'm starting to, and I'm also yelling at the children, like, what did you do? So now I'm mad. And they're dancing in the rain and they're singing, it's raining, it's pouring. Like, they're singing along. And so I just like, so I don't know what to do. Like, what do you do in that? I've done everything I know how to do. I'm at my wit's end, right? I'm at the end of everything I've tried. Shut off everything in the house. I turned the power off too because I'm like, it might short out somehow. I don't know. So what do? Pick up the phone. I call 911. I don't know. It's a Saturday. I don't know a plumber's phone number. I don't know how to get a hold of. I don't have friends that know how to do this. I call 911 because I thought my line of thinking was, well, if they can shut off, maybe they could shut off the power or the water like out in the street or somewhere. Maybe they knew something I didn't, right? Call 911. Fire department shows up. I'm like, I know this is weird, guys, but I don't know what to do. And they're like, yeah, we'll try to figure it out. So I had 4 firemen down in the basement with me, and we're looking around, and one of them moved, like, when you move into a house, they always leave all the paint behind for every room. That shelf down in the basement, they pick it up and move it out of the way. Somewhere in the 120 years of this house's existence, a second main water line was plumbed into the house, or it was a duplex or something. So there was another shut off that was hidden behind this shelf, and they shut it off, and then began 2 months of living in a hotel. Well, we had contractors come and drywall and fix the house and that. And in the middle of all this, my wife got home from work and wondered how things were going. So that's how they were going. So, okay. the point of the story is that when I got to that point where I was completely lost and didn't know what to do, I picked up the phone, I called 911, right? And people get in that situation a lot of the times with their mental health or with life in general, right? Whether it's, I don't know where I'm going to stay tonight. I'm having a panic attack. My friend's suicidal. I haven't heard from them in 3 days. And they get to that point where they have run out of options or they can't think of it in the moment. Like me, like you don't know what to do. And that number is 911. And so we created Arch as a way to respond to those situations where it doesn't really fit in the category of like somebody breaking the law or needing an emergency medical situation. And so we paired up myself, I'm a paramedic, with a social worker to do work in those situations where it maybe requires a little more time, a little more attention, a little more knowledge of kind of how the system works. And so through grant funding from the Mary Greeley Foundation and then some other support from the city, we launched Arch a couple of years ago. So that's the vehicle we kind of respond in. Other than the logo on the door there's really no other way to identify the vehicle, right? We've got some flashy lights that are hidden away just in case. The other day we came up on an accident that had just happened out at the front of the hospital. So I was, turned the lights on there. But other than that, it's really a discreet response. And that's because a lot of times, people are embarrassed or they are hesitant to call because they don't want to have the fire department come, the ambulance come, because they really don't want people to know what's going on. So that was one of the reasons we did that. So in 2024, we responded to 552 individual calls in the city of Ames. So we stay within the city because we have limited funding and staffing and that sort of thing. Obviously, there's crisis all over the country, really. We were in service for 244 days, which is, those are days that we're on. So, Monday through Friday for the most part. We had a small dip in service because our social worker left in August, and then our Becky was not hired until October. So August, September, we kind of had a dip in our numbers. 220 missed calls. So what that means is days and times when we're not in service. The Ames Police Dispatch, that's how we hear about the calls. They dispatch us like they would any other emergency service. 220 calls happened while we were not available. So overnights and on the weekends, or just days that someone was sick or whatever. And we spent an average of 39 minutes on a call. And that seems kind of low, but it's because sometimes we count a call where I make a phone call, talk to somebody for maybe 5 minutes on the phone and realize that there was a misunderstanding or, things like that. So that number gets pulled down. Oftentimes we're on scene for, I would say, about an hour and a half sometimes, spending time with people. And then 358 calls. Of those 552, Arch was the only unit that needed to respond. Sometimes police come with us, sometimes EMS comes with us, but 358 out of those 552, we were able to resolve the situation without involving any further agencies. So you want to hit that slide. So these are kind of the two roles that we have. I was going to have Becky talk about hers, but I can fill in there. So on my side with EMS, what I do, so I don't carry a full ambulance, worth of stuff, but I provide an assessment and I determine if their current situation may require emergency intervention from whether it's going to the ER or from an ambulance coming out. Sometimes they're just in such a heightened state of, like Susan had said, like mania, where you might need medication right then to calm down. I don't carry any of that as of now. Intervention, de-escalation, and first aid. So intervention is, immediate intervening and then having law enforcement or police or fire department come out. De-escalation is just kind of that verbal, it's kind of a verbal dance or judo, some people call it, where you kind of talk someone down from where they're at. That's something that it's hard to train for because it's hard to mimic. And so it's hard to, and everybody's different, right? CPR, I can learn and I know it's the same for everybody. I'm going to do the same thing for anybody who needs CPR. But when they're in a crisis, right, you don't know which way that conversation is going to go. So you kind of have to be on your toes. So that's part of how we're trained. And Susan and Becky are trained also like that. But it's one thing EMS stresses a lot in their training as well. And for social work, they do they kind of take over after that first assessment, and they kind of determine, okay, where are we going with things now? What needs do you have that we can try to plug you into? And they coordinate care. They coordinate with some of the other agencies in Ames as well as the hospital and help navigate through that. We don't provide any like long-term follow-up care because we try to get you someone who will, because those agencies exist, and it's just a matter of finding the right one. So we're not creating any new agency that's going to provide that. We would just rather have them be connected to what's out there. And that's why we don't have our own phone number as well. Like 988 is a good resource, the mobile crisis number. We exist for people who forget in the moment that those things are out there. And the 911 is like the last line of defense, right? So they're going to call, pick up the phone. That's how you get a hold of Arch. Slide. I think this is the last one. Yeah. So some of our goals, find the right care at the right time in the moment of crisis, like I talked about, just trying to find those right needs and meet them right there in that moment. And then prevent going to the hospitals. A lot of times, as when I worked on the ambulance, a lot of what we found was that we're bringing people to the hospital in mental health crisis who have previous diagnosis, and this is kind of a normal pattern for them. And maybe they're just a little outside of their norm, and they end up going to the emergency room unnecessarily. And then that takes the doctor's time, their time, because they don't want to be there necessarily, but they just need help for a minute, and it ends up costing us, them, and it doesn't benefit anybody to do that. But that's also where I come in to kind of make that assessment and say, I think maybe you do need to go to the hospital. Maybe or no, I think you're good. I think you can stay home, and here's the safety plan we have for you. So yeah, we're trying to prevent that. We also try to prevent people from going to jail too, through talking with working closely with PD and making sure, hey, is this something we can avoid? Do they need to, obviously if a crime's been committed, they're going to do their job. But sometimes with mental health, as you see in the news, that those situations escalate, and then ultimately bad things happen. A lot of the times, people get hurt, and then the police ultimately, they start looking bad because they didn't know how to react. Now, I will say, working in Ames with our police department, they're fantastic. They're amazing at their job. I've not had a lot of, if any, negative experience with them. And it's not because of anything we did, but they're also busy with a lot of other things that they do need to be working on. And then utilize existing services. So again, like I mentioned, we're just trying to get you pointed in the right direction and help navigate a confusing system. Susan can probably attest that navigating all these different things and needs, whether it's food, housing, mental health, it's all very confusing, especially if you're new to it. And so we're going to kind of help with that. And is there one more? One more slide? Oh, yeah. So just to summarize, mental health struggles are complex, and they can bring stressors into other situations. So if you're struggling with homelessness, mental health compounds that stress and creates more problems as well. So that's kind of something we help with. And then navigating the healthcare system when you have mental health needs makes that all the more difficult, because if you're trying to talk to your insurance company on the phone and you have voices in your head, let's say, and you're schizophrenic and you're having trouble even having a normal conversation, how much harder is it to call an insurance company, wait on hold for 30 minutes and then try to talk to them, right? So we kind of help support that. We get family members involved as much as we can. But then when it becomes too much, or a family doesn't know what to do, or they don't know what to do, then they go to hold of Arch and we kind of help push past that crisis. So I know we're slightly over time, but if you have any questions for Susan or I.
can take the microphone.
I had a whole list, but you answered a lot of them.
We'll have to use the microphone if that's okay, so that people who are listening online.
So I know.
I know that you don't carry a complete medical supply, but do you carry Narcan? Are you, okay? And then did I understand the only way to reach you is to call 911 and it's up to that staff to refer to you?
Partially true. So yes, 911 is the way we tell the public to get a hold of us. There are some agencies that will use the non-emergency police number, which is, I never remember. It's 239-5133. And they can request Arch to come out. But we really rely on dispatch, and that's for a couple reasons. For our safety, so they're still going to follow their same questions they would the normal 911 call. And then it also helps them kind of tell us what's going on. So we just, we've collaborated with the dispatch people as well.
And so in the future, is your goal to increase your staff so that you'll be able to increase hours and to reach people more?
Yeah. So,
And so I'm very familiar with art, and so I would encourage anyone to support funding through the city, Mary Greeley, to continue this program.
Yeah.
We're really lucky. We're really lucky in Ames to have them.
thank you.
Mhm.
What's your funding source today?
So right now it's a split between the city and the foundation. So they're basically 50-50. I don't know all the ins and outs of how we get the money. I know there's kind of they have an agreement together because we're hospital employees, but we're also helping them out quite a bit and working pretty closely with them. So I don't know the details. Melissa from the foundation is probably one who know better than me. So
You can reach out to me or Vicky. You have our emails and we can connect you with Melissa anytime.
You serve the student community as well?
that's a great question.
For the people who are online, she asked, are you serving the student community as well?
Yeah, so at first, we had a hard time kind of breaking into that realm or that area. We did talk to the police department there at Iowa State. They were open to the idea, but also what we found was happening was there's a lot of good mental health resources for the students. And so they were always kind of told to go with what they had available, but we're finding more and more we're getting called into that, into the dorms and things like that. One of our part-time people that works for Arch is also the mental health advocate for Iowa State Police. So she's kind of helped orchestrate a little bit of like, hey, awareness, like we're here. Again, we want them to use what's available, but then there's times we're called out there. So we're more and more. So I mapped it out and you could see the first year there was kind of like, it was like a heat map. So there was like a little bubble around the university, but we're slowly kind of working our way in there.
I feel we have so many young people in Ames that, you know, they're a source of, they live in a crisis mode maybe.
Absolutely.
And I have another question, which was, if someone calls 911 and I assume there's a maybe list of questions that they go through, at what point do you find out if they're firearms?
I want to repeat that question for you.
Yeah, so the question was during the course of the dispatch, at what point do we find out if firearms are involved? And that's a great question because it's obviously goes to our safety. It's usually before we get there. So they'll ask all the questions. And if there's any threat of harm, whether it's self-harm or harm to others, or a history of kind of domestic violence issues or anything like that, they'll let us know. Oftentimes we'll request an officer to come if they're known to have weapons. We do have a little tablet in our, that Durango you saw the picture of. So we can pull up notes and things from past calls at certain addresses. And we can look and see if there's been violence or weapons involved there as well. So we're pretty well prepared. Obviously, you can't be 100% sure. And that's part of the job, but I found that we tend to de-escalate people just by the way we look, because we're not carrying weapons and we're not dressed with all that stuff. Not that that's bad, it's just part of their job, but yeah, I find that people who are violent tend to de-escalate more just based on our appearance. And so, yeah, if we've not had any situations where we've been in danger so far, thankfully. Not, but, yeah, yes.
Will you go out? Sorry. Will you go out a few miles outside of Ames city limits?
So as of right now, no, just because of our agreement with the city. We're exploring kind of what we can do to reach the county, especially towns like Gilbert, Story City, Nevada, where they're bigger in population and also fairly close. I mean, I live in Collins, so I don't think we'll be stationing anybody out there, but maybe if they're in Nevada, that's only a 15-minute response. So we're looking into it. It's just kind of, we're not really sure how that plays out yet. So
I would like to add, so typically if you have someone that's a couple miles out of Ames Mobile Crisis,
Mhm.
that Your Life Iowa would be the one that you would want to contact. They will travel anywhere within, well, we're regionalizing, I can't say the word. So they will travel. So they would be the ones, if you have someone that lives a little bit out of Ames, Mobile Crisis.
Reach the 911 again.
That's Your Life Iowa. So that was on the slide. It's probably in your packet. And if it's not, I can maybe Allie can help you look at that and make sure you star that. And that would be who you would contact. Sorry, Nick, I just wanted to
No,
jump in.
yeah, that's
We've
good.
had that come up before where someone's called and said, oh, I'm right living on the Boone County line. Can you send Arch out? And we really can't. So.
we can make phone calls though. So if you want us to just call and talk to somebody who doesn't live in Ames, we could do that. But if it would require a response after that, then we'd probably have to be in contact with the sheriff or the police. Yes, sir.
How about if I called 988, ask for plumbing specialist?
You might, if you did get me, you'd be in a lot more trouble, I think, because I don't know what I'm doing.
I take a chance on it.
I have a broken dishwasher at home I'm trying to fix. So.
Let the kids do it.
Yeah, exactly. They've since admitted to being the ones responsible. They claimed they didn't break that pipe for the longest time, and now they're older, so. What else? Thank you, guys.
Thank you so much for sharing your time with us today. We're so grateful to have these advocates in our community. So again, thank you.